One step closer to the weekend. A good Thursday morning to you. Today we're talking about loyalty and trust. I looked back at my PT textbooks this morning and in the syllabi, and I didn't see anything about loyalty or trust. It's in there, it's baked in there, but are you paying attention to it now? Loyalty and trust. And we bring in the guru. He's kind of guru-y, John Taffer. Name sounds familiar. Bar rescue. You've seen him screaming at bar owners and bartenders and waiters and waitresses on their hit show that's done 1 million episodes. What lessons can we take from Bar Rescue and John Taffer to apply to your physical therapy business or healthcare or, life? So building loyalty in physical therapy and beyond, how can you earn trust like John Taffer? Plus, we're going to do a review. This is like the dirtiest word. Have you heard? The dirtiest word in healthcare in the last couple of weeks. UnitedHealthcare. We dig in. And poof, there they are on screen. No, you're in the wrong positions. It's always Tony in the middle and Dave on the right. Good morning, Tony Maritato. Good morning, Dave Kittle. Still on location in the lost in the Smoky Mountains as Dave Kittle on vacation, but he's still doing this live stream. Good morning.
Yeah, how long are you going to be on vacation?
We'll be back the day before Labor Day, but I want to try to do like some Cal Ripken streak, man. I don't want to leave you guys out. I miss you, so I'm here.
Yeah.
All right.
Yeah, I lost my voice last week. Still showed up. Still just kept putting words on screen. That counts. That counts as the streak.
So I've got an interesting one for you guys because I know we're talking. Jimmy, what did you say we're talking about?
Building loyalty and trust.
Building loyalty and trust. Let's talk about that for just a second from a staff perspective. And this will give you some peek behind the curtain on why I'm so resistant to try and hire new staff. Okay. So I'm on a run yesterday morning. I text my team. I'm like, hey guys, I'm going to come in about 10 o'clock. There's a 10 o'clock evaluation scheduled. So I drop my kids off at school. I go for a run. I'm about a mile away from the house. I've been running a little while now. I get a call and it's one of my physical therapist assistants. And I'm like, hey, what's going on? And she was like, I just threw up in my car. I'm in the parking lot at the clinic. I don't think we have any patients for another 30 minutes. I am so sorry. I can't stop throwing up. Meanwhile, she's pregnant. She's due like early November. And I'm like, oh my gosh, totally don't worry about it. I am going to be there. Let me get back to the house. I'll just get dressed and I'll come in. She was like, I'm so sorry. I feel so bad. I'm like, seriously, you're like 7-8 months pregnant. You're puking in the parking lot. You still showed up to work to open the clinic. I'm like, it's okay. We will be fine. Just give me 10 minutes. I'll get in the car and I'll be right there. Like that kind of personality, that kind of dedication. Like I don't even want to interview for that. I don't know how you find something like that, And so dedication, go ahead.
But look at the reverse. Like that is a hard phone call to make. I'm guessing I've had to make that phone call. I've never been 8 months pregnant. I know it surprises you, but I've had to make that call, and I can feel a visceral reaction when I had to call my former boss, Chris, or a different boss. And if I called Chris and I was like, "Hey man, I'm sick," and threw up in the parking lot, he would have said, "Go home." Like, are you okay? Do you need me to come get you? Go home. So it works both ways. Like there is that. Hey, I wouldn't even want to look for that. How would I find that? I don't know if you I think you need the right ingredients, but it needs to be both ways. Like it's the ingredients and you need to cook it right. You have bad ingredients, boy, it's never going to happen. You could have great ingredients, but you cook it wrong. So I think it's on both sides. You have to understand. I think I wrote this in the chat yesterday between us. You have to understand, does everybody on the field understand what game we're playing? Do they understand what position they're playing? And do they know how to play that position well? And I think you just described a situation where the answer is yes to all three of those.
So the problem is that Tony is just discounting the entire available hiring community, any therapist. Like, is everyone going to be like that person? Probably not. Is every PT or PTA going to be like that? Probably not. Maybe after a couple years, or maybe never. But Tony, I want to grab you and shake you and say, we're here for you. We're here for you. But at the same time, no, not every candidate's going to be like that. Not every team member is going to grow into, your exact culture and morale and all that. But it kills me, Tony, because I've known you for so long, that this is affecting your decision to hire or grow your team. Because if you had an extra PT or PTA, couldn't that PT or PTA right now, or when that happened, help cover and absorb some of those patients at the very least, and then you continue on your run? Maybe some of the patients you have to slide later in the week or reschedule, but you continue your run, you continue some of the home life before you go back into the clinic. So I understand like the communication and, some of these team members, because I've had some of these team members over the years, like you're describing, like, no, I agree. They're not everywhere, but it kills me when you say that this is like preventing you at all from recruiting and hiring anybody. Like that I hope we can change. I don't know.
No, you're right. You're right. It's social media. Like my, everything coming in is so negative in regards to hiring and interviews and new candidates. Social media has totally warped my perspective. There are good humans out there. I know they exist. Jimmy, you were going to say something.
Yeah, I was going to say, could you use that employee you just talked about, the reliable one, the one who's going to, almost fight through vomiting to help open the clinic, to beta test or to be able to use it as a farm system? It's like, well, having that reliable person may allow you to have someone you can take a risk on.
Yeah.
It was similar to when I was in radio. I was always taught, where are your bench players, right? Let's say your morning person leaves. Who have you been training up for the last 2 or 3 years and giving reps to on the weekends, right? Where it's safer to fail in radio terms, right? You didn't want to put the person in prime time, but hey, where's that person 3-5 years from now? That was one thing that made me a little bit nervous in radio, is with all the syndication, all these big shows being sent to multiple markets. Where are the bench players? Where's the kid who sucked in the beginning, right? I mean, how many times do we hear like the starting shortstop or the MVP of the World Series was the backup in high school? Well, he had enough reps somewhere along the way and was able to actually become the megastar that they are.
Yeah. Yeah. No, I totally agree.
Simple, not easy though. Simple, not easy.
Right. Go ahead. What's the topic?
All right, so let's get into this. So there's a long clip. This clip is 4.5 minutes. I'm going to play a couple of seconds of it, and I'll put the link to the clip in the chat. But this is John Taffer, who's the big, bellowy, screamy host from Bar Rescue, who goes around the country. He has a really narrow skill set, which is coming in and assessing bars and restaurants. And he gets a snapshot. And some people have said his show is formulaic. I would say, if a lot of PTs or healthcare professionals, they have an evaluation that's formulaic. If I go through the same process every time, I know where to spot the leaks. And he goes through this process and he finds out where the problem, can this thing be saved? If so, where are the problems? And then let's change those problems. Spoiler alert, it's most of the time it's people in psychology. Even though John Taffer is a restaurant guy, he understands the game that he's in. So it's John Taffer, for context, talking to Gary Vee. And if you don't know Gary Vee, I don't know, you've been living under a rock. Social media guy, sort of pioneered that whole document versus create, just recorded everything. And it's a conversation between these two. And John is highlighting this statistic. He did research. He doesn't cite his sources. That's okay. We still like it. Where he said, if a person comes into a restaurant and has a perfect experience, a perfect dining experience, the statistical likelihood that they come back is 40%. Ooh, I wish it was higher. A perfect experience and only 40%. The same statistic holds true from their second perfect experience to get them back for the third, 40%. But if they have 3 perfect experiences, if they have a hat trick, the statistical likelihood that they become a long-term return customer, loyal customer, goes up to 70%. So you really got to earn it in those 3. And he's talking about these tricks, or these strategies, right? It's a nice way of saying tricks on how they do that. So I'll play just a couple seconds of the clip and then we can sort of dive in.
If somebody goes to a restaurant for the first time and has a flawless experience, the statistical likelihood of them doing a second visit is about 40%. They come back a second time, and have a flawless experience, the statistical likelihood of a third visit is still about 42%. The third time they come, the statistical likelihood of a fourth visit is over 70%. So you got to market to 3 visits, not 1. Visit.
I think that last line right there is why I wanted to play that clip. You market to 3 visits, not 1. Okay. And he goes into, and I'll share the clip, he goes into strategies, and we can talk about hours, and we can rip through it faster than John in that clip. But you market to 3 visits, 3 dinners, 3 perfect experiences, not 1. My question is, in physical therapy or healthcare, do we even market to 1? Or are we just like, when the patient walks in, instead of, oh my gosh, you're here, I'm so glad you're here, is it more, I'm here, aren't you glad? So when you see a clip like that, Dave, we'll go to Dave first, because I think Tony has an experience in strategies like this. Dave, when you see that, number 1, does that stat surprise you? 2, do you think it's paralleled to healthcare?
There's some parallels, but not exactly. So WebPT, Tony knows this, 5, 6 something years ago, they put out a study, and it was like 80 or 90 or some large majority of patients fall off. I think after like the 3rd visit, the study was something like 80 or 90% of patients do not finish their plan of care. The plan of care as defined by the physical therapist who does the evaluation and then writes, this is going to be 8 weeks or 3 weeks or 12 weeks or however long, depending on that condition. So WebPT did this study that most patients drop off. There's some parallels, but it's not exact with the restaurant world, because we all go out, us 3, we're going to find one restaurant, but then we're going to go to a different restaurant the next night or the next week or whatever, right? We're going to switch restaurants versus physical therapy, where if we're deciding to get physical therapy for back pain or total knee replacement or whatever, like we're going to typically find a place, and we're going to just most of the time continue at that place. If it's, Tony will fill in the gaps. Like if the place is like good enough or, decent enough or whatever, they'll stick around to go to that one place, as opposed to the restaurant world, where it's very there's so many options in the community, wherever you're at, any city, metro, whatever, or even in a rural area, and you're going to go to a different restaurant. I'm not going to go, like, if I have Chipotle yesterday, I might go today, but I'm not going to go, like, I'm going to go to Chipotle like once a week or whatever, or the Mexican restaurant or some other place. There's some parallels here, but it's not, I don't know, it's not quite the same because of
But doesn't that reinforce it? Isn't it more important because you're not going to jump around? So if you are the person or the practice that gets that first referral or visit, isn't it more important to give the experience? Because you just said WebPT had their data that 80%. 80 is pretty close to 60, right? In terms of a 40% statistical likelihood they come back for the second dinner, which means there's a 60% statistical likelihood they don't come back. So I feel like a plan of care would be 10 dinners. That's when the host knows your name, right? That's completing the plan of care. And can we get another one? They might be off by a couple percentage points, but it feels similar, and it actually feels more risky, because once you go to PT, we hear this a lot. I tried PT, it didn't work. I didn't go back. I didn't go to
and the patient went to one place. They didn't go to multiple physical therapy practices typically.
So this tells me you're not going to get someone who had a bad burrito at Chipotle, and now you're the local Mexican place. You're going to have, I had a bad burrito at Chipotle, I'm never having burritos again. That's more the PT, that's more the healthcare parallel.
Right.
So if that WebPT statistic is correct, Tony, if you're a practice, how do you make sure someone gets to 10 visits where the bartender knows their name? And what are the strategies that we can do to build and earn loyalty and trust?
Yeah, I think there's a ton of ways. I'm curious to see what Dave has crafted in the self-pay world, because that's a whole different ballpark. Jerry Durham, I think Dave, me, and Rob Vining talked about this. We've been talking about this for decades, literally. Like for us, first things first, like I never do, as an example, provocative tests. Why? You're coming to me as a client to feel better, and I'm going to make you feel worse. I'm going to do something that flares up your symptoms. So like, I understand I need an easy win. My big thing is, hey, let's get you in here. Let's get you feeling good. Let's get you out the door before you even think you need to leave. And I tell them all this, like, this is all part of, if you guys recorded me in the clinic, you would hear the same thing over and over, very systematized. It's just, At this point, I mean, it just comes out. I don't even think about it, but it's like, let's get you in, let's get you feeling good, and let's get you out before you want to leave. This way you come back tomorrow. And then when you come back tomorrow, it's going to be the same thing. Let's get you in, let's get you feeling good, and let's get you out before you feel like you have to leave. Let's get you doing less than you want to do, so you come back wanting to do more. And every single session is a win. Every single session you're leaving feeling good. Now you can craft that in a lot of different ways. And I want to talk strategy. And I'm sure Dave's got some interesting things to say, but like as a perfect example, so we know how powerful saying or hearing your name can be. So when I was designing my clinics right from the start, the very first clinic I ever opened, I would notice a new client would come in. Maybe we knew their name, maybe we didn't, maybe my front desk person, you know, they're not treating the patient, so they're not going to remember. So we were still on paper charts. I would set the paper charts up in a position between the receptionist and the person walking in the door. So the person walks in the door, the receptionist literally has to look at the paper chart and then the person behind them to see the name and be able to say, Susan, it's so great to see you. Not because she remembered Susan and what Susan looked like, but because she saw Susan's chart and the label with the name right in front of Susan, who's walking in the door. You know, and we would craft in that clip that you shared. He talked about having a red napkin to indicate this is a new customer. We would craft that same kind of experience. So if we had 2 or 3 clinicians in the practice, one of the policies would be when a new patient comes in, I would introduce that new patient to every single person on the team. I'm Tony, you know, this is Jeremy, this is Jenna. Jeremy is the Pittsburgh Steelers fan in Ohio. I don't know what he's doing here. And we would start cracking jokes. And then I would bring my patient to, let's say, the recumbent bike, and next to them would be a non-covered wellness patient. And I would say, you know, John, this is Kim. Kim's been one of our veterans. She's been around the clinic for like a decade now. Kim, this is John. This is John's first day. I can't share any information about your case, but Kim, I think if you are willing, tell John a little bit about your experience. And then I would literally walk away. And so my patient, who had been a wellness member for 10 years, all of a sudden now becomes an ambassador and starts telling the brand new patient about how amazing it is here, how much everybody is so thoughtful and caring. We have so much fun. And I've been coming, and I started for a knee replacement, and now it's been 10 years. And I can't imagine starting my day without coming to the clinic. They become my sales force, you know? So these are crafted experiences that we've created over years of figuring this stuff out. And like that clip said, I know if I get them out the door feeling better and wanting to do more than they did, they're going to come back the next time and the next time and the next time. And once we get 3 or 4 finished visits, they're committed. Like there's no way. We're part of the family. We're ingrained in their schedule. And this is in a model where a lot of my patients come in very reluctant, not interested in doing it. They're not paying for it. The insurance is paying for it. They're kind of coming begrudgingly. And so we're trying to win them over. Where in Dave's case, you know, they're paying a lot of money to see him. So I'd be curious to see what kind of stuff you're doing.
Well, hang on. Before we go, I want to highlight 3 things that I heard, or I thought I heard you say. Sound like Chris Voss, right? So it sounds like you focused on the number of times you could actually say that patient's name. I mean, to the importance of where you put the charts. The person at the front desk had to greet that person by name, not, hi, who are you? What insurance do you have? Right? That's not the thing. It's about a name. Right. You sat them next to someone who's been there for a while and said, this is one of our veterans. What you showed but did not say is some people stick around for a while, right? You didn't sell them an aftercare thing. You said, to quote Seth Godin, people like us do things like this. So there is a path, not for everybody, but this is one of our veterans. And then you also let that person, when you walked away, sell it. We're natural like that, right? That's why 3rd grade teachers, when there's a new kid in class, puts them next to like the kid who acts really well and says, he's going to show you around the building. Right. And then that kid feels empowered that I get to be the kid who shows the new kid around the building. And the last thing, or the thing that stuck out maybe the most, was you made them feel like the star. Like, this is what I was, tweeting about for a couple days last week, which is, it's not about you. Never was. how much about this can you make it about them? How personal can you do it? Dave, you have a different model, vastly different model, right? In New York City, I'm talking about demographic, psychographic expectations, but it doesn't mean you can't do similar things in terms of trust or loyalty. What are one or two of things that that you do?
Yeah, so the one thing that we do about, like John Tavert was saying, kind of marketing, he's saying marketing for the first 3 times, like even solidifying and having a lockdown close for the first visit. So I would say, so Jimmy calls in and we schedule for, let's say Monday. So, hey, Jimmy, awesome. We have you on the books. We have you scheduled for Monday at 3:30 p.m. Dr. Chris is going to be coming and evaluating you. He's going to reach out as well. He's going to call or text you. He's going to touch base with you as well. But our clients, we know our clients are busy and they have a lot going on. So is there anything on Monday, like work or personal or any, doctor's visit, whatever, is there anything that could like run over or prevent you from doing that visit? Is there anything, I almost do like a takeaway, like a semi takeaway close. Like I want to say like, hey, are you sure you want this? I just want to make sure. So like, and if you say, no, like this is important to me. I have this scheduled. I found you guys. I like your Google reviews. It's booked on my calendar. It's locked in. It's confirmed. And I look forward to Dr. Chris coming to my apartment for my in-home physical therapy visit on Monday at 3:30 p.m. That's what we want to hear. So that's one thing that we kind of do up front. Now, in terms of the second visit or the third visit. So after the first visit in person, I evaluate, or my, Dr. Chris evaluates the patient Jimmy. And at the end of the visit, my therapist and I, we should be saying to our patients, we're talking about the plan of care, but we're scheduling at least the next visit or 2. And if the patient Jimmy says something like, I'll text you, like kind of like leave, like, I'll let you know. Like, so, we got to schedule out, like we're going to do Tuesday, Thursday. We're going to do, depending on, there's a bunch of things depending on the involvement of the situation, the diagnosis, the presentation. It might be once or twice a week. Or we have some families that start and they're like, we want daily. We want like, can you guys do like 5, 6, 7 days a week? So depending on the person and the family's financial resources. But if we're trying to schedule Jimmy for the second visit and we say, hey, let's get something on the books before I leave. Why don't we pencil in something? And if the patient says, I'll reach out, I'll let you know. We know that there's a problem. Like they didn't see enough value.
Right.
Maybe the therapist talked over them. Something happened, right? So it's like before the therapist leaves, we got to say, hey, Jimmy, it's not you, but like we have there's a pattern, like other patients over the years. And if they say something like, oh, like, I don't know, like I'll text you or call you or something, I don't know, and I'll let you know. I just want to let you know, like, that's fine for you to say that, but we've heard that from other patients over the years. And what we found is when they say that, there was either some disconnect or they're not looking to schedule that second visit or third visit. Is there anything that we can, not to confront it like in a combative way, but hey, let's flesh it out. Let's flesh out some objection or whatever. So maybe it's like, hey, I really don't have the dollar, like I don't have the budget for $250 or something per visit, or the therapist talked too much or didn't do manual therapy when the patient expected manual therapy, or vice versa. Mm-hmm. So there was something, but that helps obviously the communication with scheduling and getting the second or third visit booked out. Obviously things are different in a mobile practice versus Tony's brick and mortar, but those are some of the things that we've seen that will be an issue or a challenge or a barrier for that second or third visit.
Let me break down what I thought I heard you say. I think you're increasing the status of your first visit when you're asking questions like, is there anything that could come in the way of this? Like what you're saying is, this is a super important thing that we're going to send someone out there. This is a big deal to you. Is there anything that might cause this that would run late, that would cause you to miss this? In my view, that's increasing the status of that thing or the importance, right? So I think that's a way to show it value without having to say. It's a show versus tell. And
it signals their level of seriousness, right? So like we want them to we want them to say like, heck yes, like this thing is confirmed and booked and I can't wait to rock and roll with you guys. I can't wait for this evaluation. I really need to address this. I've I've had this issue for too long or whatever, and I'm looking forward to it. As opposed to someone that's kind of like wishy-washy. Laid back, wishy-washy, like whatever, who knows? And then it's like, oh well, we need to flush that out and address it. Dave
doesn't want to get text messages from his therapist on Monday afternoon that says the guy bailed. It's like, because you reinforced this is a big deal, and instead of saying You're not going to bail on me, right? That's like that's a way to like reduce signaling in a negative way. Where you're saying, is there anything that could get in the way of us providing this? The second thing is you mentioned is you're talking about the future. You're sort of signaling like it's not one and done. Like, let's talk about what's next, right? So you're ushering them to that, to making sure that instead of saying, you understand that the magic's not over yet, we got to keep going. You help me understand like what's good for you, or you're tailoring this to them. You're making sure it sounds like they're part of the process too, which is we know is the IKEA effect, which is if I have some say in the process. It's why Legos are so popular. It's why I learned Betty Crocker used to have cake mix that you poured and just added water. And they realized that women in the 60s or 50s, 60s didn't like it. They increased the complexity by saying you had to have water and one egg, and sales went through the roof. It's the IKEA effect all over again. It should have been the Betty Crocker effect because Betty Crocker was around first. And then finally, you're there making sure expectations were reached. The goal of the first date is not to get married. Goal of the first date is to get the second date. And when I say it like this, people are like, of course it is, Jimmy. How'd you figure that out? You're not married. But then I'll flip that on people and say the goal of the evaluation is to get the second visit. And they're like, well, no, we want to complete the plan of care. My man, the only way you complete the plan of care, if we're mathematically saying it's 10, is to get to number 2. But we just say, well, I've got them and I've told them there's 9 more visits. They're going to show up. You have to earn the second date. If the first date is weird or crappy or didn't have expectations or I can't see myself, never mind the second date, definitely not the 10th date, you lose. So you have to, this is where we go back to John Taffer. You market to win that third date so that fourth date happens. And then the statistical likelihood, if we say his math holds true somewhere else, the statistical likelihood goes way, way up. And that is about making sure everybody on my team knows what game we're playing, what positions they play, and can they play it well.
I'm surprised Dave hasn't said this, because Dave's a big copywriter, a big fan of copywriting. Everything about copywriting is, what's the purpose of the title, the headline, to read the next sentence, and you just work your way down till you've completed the whole story. Something that I wanted to mention here too is, I think so many of us think we don't have the capacity to tailor algorithms, in a sense that, like Dave is saying, so when I start to sense some hesitancy, when I start to get a sense for this person isn't really bought in, or they're here for a different motivation, I should have the ability to create or tailor a customized program for that person. Classic example. So we used to do a ton of post-surgical, non-surgical, low back pain referrals. We had 2 spine surgeons. Everybody who wasn't appropriate for surgery would get referred right over to us. Well, a lot of these patients have zero interest in doing physical therapy. So we had to create a system that could accommodate, okay, this person's going to schedule, but I can't block a spot on the schedule for this person who has a high likelihood of not showing up to that appointment. It could be low motivation. It could be transportation. These are a lot of patients that had transportation limitations. They were scheduling public transportation. We had no idea where they were going to come. So because we as a business chose to accept those referrals and try to help that population, we had to create a custom way to serve without sacrificing everybody else. So what we would do is we'd book an appointment, but we would make it gray on the schedule. Gray indicated this person's not likely to come. If they come, we will serve them, but we are not saving a dedicated spot. We will book other appointments in that same position. And so throughout the years having the business, we always made decisions. Are we going to accommodate this customer, this client? And when I say that, I mean a population. Yeah. So are we going to accommodate people that may need genuine in the room? Like I'm in an exam room right now. The only thing I do in this exam room is talk to you guys. I never let a patient in this exam room. But there was a time where I would accept referrals who might have to come into this exam room for various reasons. I don't have that business these days. I don't do that. But having the versatility to say, like Dave said, patients motivated, families dying, I'm going to see you 5 days in a row, because let's take advantage of the motivation and the enthusiasm you have right now, as opposed to somebody who maybe like, I want to test the waters. I'm super busy. I'm traveling. I'm doing all this stuff. No problem. I'll see you once in the clinic. We'll do 2 or 3 telehealth sessions. Like, can you customize your plan of care to meet the patient where the patient's at?
So that goes back to the very first thing we talked about on this live stream that we did not plan, which is making sure your employees, your team members, understand what they're allowed to do, right? To say for John Taffer, it would be like to make sure you understand as a waiter, if you go over there and you're getting negative vibes, man, you know, the guy, his wife, and the kids, they're negative vibes. And like, hey, is there waiters and waitresses are always good, right? Put the entree down, leave, come back in 5 minutes. Is there anything that I could fix, right? You've all had your first or second bite. This is the time. This is the choke point of when you want to stop a problem from progressing 40 minutes later. So making sure your team understands, hey, if their steak's undercooked, number one, I'm going to fix that right now. And instead of just saying it's off the bill, keep in mind, by the way, the round of drinks is on me. Something, making sure they understand what's on their menu for making it right, because their job is to get you to the third visit because they understand the game that they're playing and the position that they play. I purposefully went to you guys before I went into the strategies or the things, and I want everybody to take a look and a listen to this clip. But Tony sort of mentioned that he puts the chart in a certain spot and the person's name. John Taffer said in his restaurants, if it's your first visit and the host knows that because they say, is this your first time dining with us, right? That's you whispering in their ear. They all get red napkins. Now, everybody on my team understands. Now, red napkins are going to blend in if I'm just eating dinner. I don't notice that. It's a napkin. Everybody on my team understands this is important, right? It's not your table, but maybe you're going to lean over and you're going to pay more close attention as a waiter or a bartender. You're not going to miss on this one. At the end of that dinner, it's your first red napkin, which means you get a free dessert. Low cost, high perceived value, low actual cost. Maybe it's a round of drinks, but understanding what things bring people back and when in the journey you should drop them and offer them to them because you understand the goal to get them to the fourth visit. Because if you do, the statistical likelihood goes way, way up.
Real quick, the exam room analogy about cancellation, no shows, arrival, all that type of stuff. When my first job, I feel like in an outpatient clinic in New Jersey, when I was doing the evaluations in the exam room that you're talking about, Tony, I feel like I got like better. I felt like there was an acceleration of rapport built because it was just my patient and I, evaluation, hands-on treatment, some HEP, whatever, as opposed to doing the evaluation out in the big clinic and it had like 20 treatment table plinths, like it was huge. And there was like a lot of noise and the overhead music and a lot of conversations going back and forth. And I'd be curious if anyone watching or listening, comment below wherever you're seeing this or live or on the replay, what you guys have seen over the years, the difference between doing an evaluation, the first visit in a private exam room versus out in the open in the clinic. And I know that there's pros and cons of both. Yeah. And it's funny. Tony's saying like he only uses the exam room for these video calls now. And like I did a little bit of both over the years. But specifically with the exam room, I remember that it seemed like, I don't have any numbers to back it up, but it seemed like the return rate, the completed plans of care, it seemed like would have been better from the evaluations that I did with those patients in that exam room, just like Tony's sitting in right now, watching on, if you guys are watching on YouTube, compared to if it was out in the busy clinic. And I still would do the thing that Tony mentioned earlier, and every clinic should be doing this, which is you have your new patient come in and you introduce them to all the team members because, especially because that patient or the clinic has an issue like Tony just had this morning. So that patient might be seen by me next time instead of Tony. And so if that patient already met me in person, then the person at the front desk says, hey, Tom, hey, Tony got sick. He was the one throwing up this morning or whatever you say. But now you're going to be seen by the PT or PTA, Dave. And the Tom is like, oh, well, I in the back of his mind, he already met me. So he's like, all right, he's more likely now to show up instead of you move him over to a clinician that the patient has never even met, just like a random name. And then it's more likely that visit is going to be canceled. So that it does take a whole team approach for this to happen.
So I want you to think about this question before I respond to the room question. I'm curious if you have a system for routing new referrals to your clinicians that are working for you. Because what we've always done, and I still think to this day, this is the best method, but it's hard to reproduce. I typically, because again, I don't do follow-ups, or I do them as little as I possibly can. So I am always routing new referrals once I do the evaluation, who's the appropriate person for them to work with. And I do it based on personality more than anything else. This person's personality will match that clinician's personality. I'm going to put this patient with that clinician. In regards to the room, and this is something that I've been talking about on social media a lot, you know, I'd be curious to know who's out there testing these ideas, who's out there testing these hypotheses, because here, at least, you're right, 100%. If I truly wanted to build a deep rapport with the person sitting in front of me, I'm going to bring them into the room. I'm going to have a quiet chat with them. I'm going to offer them some water, some tea. Like, we're going to do all of these things. This whole episode today has been about kind of giving that top of the line experience. However, business is about compromise. Business is about finding that sweet spot between price and value and all of those things. So when I look at it, I say, yeah, I could do that. But does that, if I didn't do that, how much do I lose? I have measured this repeatedly. I lose zero in regards to patients deciding they don't want to come because I didn't take them to an exam room. I establish the expectation right from the start, just like Jerry Durham always talks about. When they walk in the door, they don't sit in a reception area. We go right back in. Most of the time, the first thing they're going to sit on is not a chair. Most of the time, the first thing they're going to sit on is a recumbent bike, a UBE. They're going to stand on an elliptical trainer, and they're going to start moving while I'm doing my initial interview and my intake and asking them questions, because I want to plant the expectation that you are not here for the socialization. We'll get that. We'll have fun. We'll joke. We'll do all that stuff. But we're not going into a private room. We're not that kind of clinic. We are going to come. We're going to move. You're going to feel better, and you're going to leave. And that's the expectation, the experience that I want to deliver today. Not what I used to do 20 years ago, but today. And I don't see a decline in rapport. I don't see a decline or a drop in returns or anything like that. I probably have the highest level of plan of care completions than I've ever had in 24 years of private practice.
It highlights what we think is valuable, might not be what the other person is thinking is valuable. I mean, I went on a topic deep dive in terms of, you know, this golden goose, this one-on-one for 60 minutes is the gold standard. And I'm like, I got to be honest. If you flip that to other businesses, shouldn't it be, if you can provide the closest experience or service to my expectation in less time, right? The plumber who can unclog my toilet and be on his way in 15 minutes is better in my view than the person who can do the same thing in 60 minutes. So just because we think we need 60 minutes, does the patient want 60 minutes?
Unless the person hiring the plumber is lonely and wants somebody in their house for 60 minutes and misses their children and wants to make food for somebody and wants to give them drinks and wants to hang out. But back to
been there.
What are you selling? You know, are you selling companionship?
What are you selling?
Amazing. Don't put a PTOT SLP label on it. Don't bill insurance for it. And hire more people, open up your ability to access a larger population of people who can deliver companionship.
Right.
But we're not necessarily in that business if we're billing insurance.
Correct. Right. Actually going outside of insurance and not, you know, this is where, again, I got to bring Megan Brown on here because this is all theory, what we're saying, right? But Megan Brown is an example of someone who's doing it. So Megan, I'll make sure I get you on here. But this is the question that I ask, and it sounds like I'm being a jerk when I ask clients this. It's like, what business are you in? And they repeat back to me their degree, or they repeat back to me, I'm a company, I'm a this company, or I'm a this association. I'm like, great, that's how you deliver the thing that you think you're delivering. What are you actually delivering? And I think people are going to hold on to this into the ground. Companies have run themselves into the ground doing this, is not understanding what business you're actually in, who you're trying to serve, and is there a mismatch in expectation? My friends, that's why things decline. Sales, membership, people showing up, that is why things decline, is when there's a mismatch in expectation. It's very rarely because of a couple dollars on price.
And speaking about insurance, we have a segue that you want to pull up.
Yeah, right here. So this was the article that Dave, you shared with us. I saw this floating around. Some people making some comments on it. This is from Becker's Hospital Review. The headline is "One of the worst situations a CFO can be in." That's the quote. Inside a systems split with United Health, and this is a small vignette, a small story of Carson Tahoe Health out in Utah, who have decided they're not small. They're 2 hospitals and like 20 outpatient centers. So that's small in hospital system speak, but they're not small, right? And what they've said is we've given UnitedHealthcare I believe it's a year's notice that you're fired. And we're doing this in a year because we care about the people in our community. We want to give them the biggest heads up. But when we negotiate something, you're either not paying us what we've agreed upon, you're paying us 40, 50, 60% less. We can't operate and serve your customers by doing that. If you keep doing that, and you're taking so long to pay us, or you're putting up so much barrier, you're costing us money at every step. So you're fired. Now the problem here is this is not one-to-one. There's a triangle here, right? Because you have the hospital system, you have United Healthcare, and then you have all the people. And the people, in my opinion, are being held hostage this way. But what happens is that the hostage situation, they look at the person they're actually in contact with, the providers, the hospital, the outpatient clinics, and saying, why are you going to make it so hard for me to access my care? When in reality, United Healthcare, as it seems in this Becker's article, is actually making it not even financially rewarding, but financially not feasible to continue this relationship. So this is a big picture example. Why, if a hospital system of 2 hospitals and 20 outpatient clinics can fire an entire health system, why not you, a singlepreneur or a clinic or a couple clinics? Why not you? Is this the only way as providers and business owners, we get to gain leverage and get their attention? Because if we keep going, it looks like we just continue to lose.
Dave, what are your thoughts?
Well, so we bill United Healthcare out of network. Tony's been in the in-network game way longer, so I would say I want to hear what Tony has to say. First of all, your initial impressions, and then also, or maybe if you want to start with this, like, are you guys still accepting the United Healthcare Medicare Advantage plans, or do you not accept those at all?
We do.
So since you do, give us some insight. Like, what are you seeing? Like, obviously you'll have, like, tell us either what you're seeing with prior authorizations, any changes, more clawbacks, more of the, just like from the article, like some of the retro payments where they're just clawing back money from like a year ago, or sometimes further in the past, like years ago, which is insane. What are your thoughts? What are you seeing in your practice, or what are your thoughts in general of this shift where some of these big health systems now are going to start dropping United Healthcare / United Healthcare Medicare Advantage plans? I think it's potentially positive. I mean, but other than the patients that live in those communities, because now they're not at fault. Like they're gonna say, hey, like my employer has chose United Healthcare. Like they literally have no leverage. But then the article also shows that the hospital systems have no leverage. Like Jimmy said, the 13,000 patients they're serving and 2 large hospitals, and even they don't have leverage against United Healthcare. So either what are you seeing in your practice, Tony, or even from the national view of this, potentially part of the, top of the iceberg as a potential shift, or maybe it's no big deal. I don't know.
I'm going to say, we lived through this here in Ohio, where I am, Middletown. Little context for everybody. There's probably 1 or 2 large employers in the area. They were with United Healthcare for a while. They switched to Anthem, Blue Cross Blue Shield, but the primary hospital in the city got into a battle with the insurance company and tried to drop the insurance company. I think this topic is largely just posturing, because effectively what's happening here is they're trying to find leverage. The hospital is trying to find leverage and saying, look, we're dropping the network. None of your beneficiaries are going to be in network. We're the only hospital that's available to them, or 1 of 2 hospitals that's available to them. Your beneficiaries are going to drop your insurance and switch to a different carrier. That's the play on the hospital side. On the insurance side, they're going to say, look, I've got 100,000 beneficiaries in this community. We're the primary payer. We have the most people. you can drop our contract, that's fine, but then you're going to lose all of these patients. Who has the bankroll? And this is a real question. Like, you guys know the financials. Who do you think has the bankroll to be in this standoff longer? It's the insurance company, right? The hospital does not have the resources and the finances to do that. So here in Ohio, when this has happened, it's happened twice in like the 20-ish years I've been here. Every single time the hospital backs down. Every single time the hospital loses. They might get one or two little breadcrumbs of negotiation from the third-party payer. It doesn't matter that the patient, the beneficiary, is the one that suffers. It doesn't matter that surgeries get canceled. All of this stuff goes on the back burner. The hospital always loses. The hospital always backs down. So that's been my experience in this kind of situation. From my experience as a small provider with a company like UnitedHealthcare, my Facebook group is full of therapists who say a year later, United came back and they clawed back all this money. And the thing is, most of the time, if you really look into it, it's a case of you don't know what you don't know. Like, okay, so UnitedHealthcare for a while switched their policy to say, we need you to document time in, time out. If somebody was treated during a certain time of the calendar year when this policy was in place, they've rescinded the policy since, but for a while that policy was in place. So you can imagine, I treat a patient in March of 2023, UnitedHealthcare comes along and audits those accounts sometime in 2024. They won't tell you why you failed the audit, but when they look at the documentation, they don't care how much you documented, how well you analyzed their gait, how well you looked at the nuances of their SI joint and all of it. They don't care. You did not document time in, time out. During those dates of service, you were required to document time in, time out. We want the money back. And that's it. And they get the money back. They're not responsible for teaching you how to bill. They're not responsible for making sure you understand the policy. But therapists don't understand that. And they're like, I can't believe they took my money away. I worked so hard.
Yeah.
Jimmy?
They don't want to understand it, right? This is an emotional thing.
It's not a priority.
Right. So it's like, listen, but this isn't quality care. It's like, understand what game you're playing, what position in that game you play, and how you can play that position well. I mean, I got to find this article, but it was, they did, a massive artificial intelligence review on PT documentation specifically. And the two main findings they found were, we were documenting more than was required by the insurance companies. The insurance company said, do X. We did X times 2 to be safer. Like, the insurance company didn't make you do all those things. They actually said, hit these 5 things. I'm making that number up. But hit these 5 things and you're fine. We did 15 and said, these guys make us do too much. No, you're doing the wrong thing. You emotionally thought you had to do 15 to feel safer. That's a you problem. And the second was in the AI review of documentation was, we did X number of things and billed for X minus 3. So we did 5 things that we could bill for, but we billed for 3 of them and then said, you guys don't pay us enough. Actually, you left money on the table, and the insurance company is not going to come wipe your butt for you. They're not going to come say, hey, by the way, you did 5 things. You only asked for 3. We're just going to go ahead and give you 5, because they understand what game they're in, what position they play, and how to play that position well. And I'm sorry, but wishing and saying it's not right, it's wrong, is not how things get changed. I'm very, very sorry. Clean up your house before you bitch about someone else's. Now, I'm not saying this company, by the way, I'm not pro that these guys are doing. These guys are playing a money game, which sucks, because we're not playing a money game. We're playing a human being relationship care game. So that sucks. So we're playing 2 different games. So understand those 3 things.
A real quick sidebar, Christine Cornegi, thank you so much for the question. I will answer this next episode. How about that? Just because we're running out of time a little bit.
It's a longer question, but it's a good one.
Yeah, mobile concierge side gig that she's starting, and she's asking how to create a positive, fun environment in someone's home. So I would love to answer that, and we could talk about that next time.
What I think she's asking, and I can only see part of the comment, is, hey, listen, Tony's creating this cool environment with people and other patients and other providers. Dave's one-on-one in someone's house. Like, how do you do that? And there are ways, I'm guessing, that you've loaded up and you've done through trial and error, or by listening to podcasts and yada, yada, by doing that. So that's a good one, but probably more than 10 minutes that we have left.
Yeah. But so going back to the UnitedHealthcare thing. So like Tony said, this is like a little bit of posturing. This is basically like a negotiation tactic.
Sure.
And here's like, so physical therapy practices, PT, OT, watching, listening right now. Tony is saying, Tony, you're probably right, that the hospital, it's just some, posturing, it's puffing their chest out, and then eventually they're going to cave. Maybe, like you said, they're going to get, I don't know, like a percentage or two back or whatever, that they're like Jimmy said, they're getting slashed by, I don't know. It doesn't say numbers, but it could be, dozens of percentage points, plus the timeline and all the administrative labor and burden and frustration of trying to get paid what the contract says. So by the way, but for the PT practice listening, you actually have the ability to not just posture, but you can actually say, I'm done with it. And then when the next patient calls that has a Medicare Advantage plan, UnitedHealthcare, whatever, you certainly can drop these lower paying payers, or especially UnitedHealthcare, the ones that are causing some of this frustration in your practice, and the administrative burden of chasing some of these dollars. And then you get paid, and then they try to claw money back 6 to 12 months later. I get it. I've been there. I've been there specifically with UnitedHealthcare, even through the out of network. And if you want to sleep better, if you want to actually do this, you can absolutely do this without posturing. You could just cancel the contract if you wanted to. The next person that calls in that has Medicare Advantage plan, you just say this. You say, hey, Tony, yep, we used to take UnitedHealthcare Medicare Advantage plan. We took it for years. We have so many patients in the community that have that we accepted it, and we've helped build their insurance, whatever. However, things have changed. There's all this paperwork, this issue. I can send you a link, this newspaper article if you want. But basically, what it means is we used to take it, and we no longer do. We no longer take it because of all this administrative burden, and they're slashing our reimbursement rates. And we believe that we're providing a valuable service to our community. And we also now, we can help you. We can evaluate and treat you. It would be on an out-of-pocket basis. And we have many clients, many patients in the community that have your Medicare Advantage plan through UnitedHealthcare, and they have decided to pay us out of pocket. It's not for everyone, but that is one way that we could continue to work with you or clients like you that have this insurance. And you certainly can just drop it. You don't have tomorrow. You don't have to take this insurance ever again if you don't want to.
Yes to what you said. It's too many words though. There needs to be we don't do, we do this now.
Well, if you've not been on these calls though, Jimmy, with an actual patient that is expecting insurance when they call in,
totally get it.
and you're saying, and I'm saying, like, we don't take it. We used to take it. We no longer do it. I believe maybe that this is just how we roll. It does require a little bit of context.
Hold on.
Because they're calling in and saying, do you take this insurance? It says it on your website. It says UnitedHealthcare. And then we have to say, we take out a network or whatever. Like it takes a little bit, because it's not like the restaurant thing. It's not like, hey, do you have ribs or chicken, or do you have a table that's available for 4 of us tonight at 8 p.m.? It requires some context because of this whole third-party payer system.
Well, I think the difference is because you're asking if it's Visa, Discover, or Amex before I ever sit down when I'm making the reservation, and you have to say we used to take American Express, but we don't anymore. But people typically don't have multiple insurances, so I can't just pull out my Visa when you say I don't do American Express. Why? They charge too much. It's like I just want to know if I can get the table right. Like, you not getting paid enough from UnitedHealthcare as a provider is a you problem. I don't like sharing my problems with them. Their problem might be, and I would address this, we used to take them, we don't anymore. Why? If they ask why, it's a payment issue. Because you're still trying to solve the person's on the phone's problem, which is how do you get them better?
I've tried it that way. It comes off too curt. It comes off too like, we don't take it anymore, and that's why. So I don't want to be a sheriff on the phone. I want to say,
what do you want to be?
I want to meet them halfway. I got bees in my face out here on the deck. I want to come off as like approachable. I don't want to come off as we're some stuffy practice that is only out of pocket.
I'll tell you right now, you're not a sheriff, but you're not that. Right now, your word salad, and it sounds like the vibe that I got was you were talking about why you broke up with your ex-girlfriend.
I think next time, at some point, whether it's not the next podcast, but at some point we should do some role play.
Yeah.
We should work through this because, you know, this is the famous, do you take my insurance question?
Right. It's the big one. No one knows
Dave's
how to
got
answer
so
it,
much
right?
experience in that world. I also think that there are a couple, you know, compromises we can bring in there. I'm happy to share what we used to say back in the day when we were out of network or all cash pay also.
It's a great
I
poll
think
question, too.
there's definite different approaches to it, but having us go through, maybe Jimmy's the patient, Dave's the provider, and just kind of listen to the actual conversation. I think that'd be great content in the future.
We should have AI do it too. You know what I mean? Like,
yeah.
load it up and be like, so you're the bad guy. Okay, AI, now switch roles. Now you're the provider. Okay, AI, switch roles. Now you're the patient. How do you get that so that everybody wins? Or, well, so I'll go, this is the last thing I'll say about this. Your goal in that conversation, from my opinion, and I don't have experience doing this, right, would be your goal is to gain understanding, not to get them to want to choose you at that point. Because if that's the deciding factor and you're not taking them, then you're not the right person for them. So your goal is to achieve understanding, right? Not make them feel bad for you or want to book despite that. Like, I think we need to understand what game you're playing, what role you play, and how to play it well. But I don't think we know the answer to the second two in this situation because it's sticky. It's hard.
Now, it might come off as a word salad real quick, but we do transition very quickly. We'll say, here's why we don't take it anymore, etc. But then it's like, we don't take it anymore because we want to provide whatever it is. We might say one-on-one time, or we want to send a doctor of physical therapy that is excellent. And in order for me to, and I know it's still some of the, you know, here's why I broke up with my girlfriend before, I understand. But we want to shift it to them, and here's why, and we can't retain great talent if we were to take these contracts, or et cetera.
Yeah.
But really, ultimately, it's so that we can provide the service that many other New Yorkers love. And maybe it's not right for you, but here's the way. Here is the pathway that we can make it happen. It just happens to be out of pocket. And I just believe that it takes some of, you can call it word salad, it takes some of this context on the phone, because they're calling in a lot of times, especially if the patient's like 30, 40 years old, whatever, 25 years old, they're just like, they're conditioned by their parents to call, ask about insurance, whatever, everyone's conditioned. So in that call, in a couple seconds or a couple minutes, I have to change their brain from 180, from the insurance is my only thing. I need to find if they are serious about finding the best results, the best outcome, someone that can be professional on the phone, can ask them questions, get them talking about their condition. Oh, we have a lot of patients and clients that have that condition, you know, Dr. Chris or whoever, or back pain or whatever. So we immediately shift it to them, and we want to make the insurance less of a focus. So we have to focus on it for a second. We put spotlight for a second, and then we shift it back to the patient. So that's what I've seen work. And maybe it could be shorter, but it is what it is for, you know, how I approach it right now.
Parting shots? What do you got, Tony?
So I'm going to do a parting shot based on that. And this will be a teaser for when we actually have this episode. You know, I think one of the easiest, and I didn't do this back in the day because I didn't even think of it. The easiest way is to be like, what is your goal? If you were to give me one goal, what's your goal? Well, my goal is to be able to travel. I can't travel the way I used to. I love travel. I want to go to Europe. Well, unfortunately, your insurance policy does not cover that as a covered service. Now, your insurance policy will pay for you to eat and sleep and bathe and dress. If you want to stay in network, go to a network provider. Those are the goals that they can help you work on. But if you're already doing that and your goal is golf, travel, pickleball, whatever, these are the prices. You know, just think about that for a second. Just start with, what is your goal? Why do you want to have therapy? And then we'll build on that next time. That's my parting shot.
Dave, what do you got?
Parting shot, going back to the the awesome video share from Jimmy, the John Taffer, Gary V, back and forth about the first, second, and third visit to a restaurant. I love talking about this, obviously, and there are certainly parallels to the restaurant world and physical therapy. And so, yeah, I mean, if you're not doing some of those things, especially if you're a brick and mortar office, if you're not doing the simple things that Tony mentioned, like take your new patient, you can evaluate them in the office, in the exam room where Tony is, or out in the open, in the gym, whatever works for you guys. Introduce them to all the team members. Such extra level, like, genius of Tony to introduce the new patient to some of the current patients or clients, or specifically the long-term patients or clients that have been there for 10 years or whatever, and just do that intro and then walk away like Tony said. Like, just play back what Tony said on this and just immediately implement it, coach your team on it. It's really, really simple. And the funny thing is, like, I didn't say it earlier, but one of my mentors, Rick Roscoe, he sold 4 clinics to USPH years ago. And then he was my mentor and helped me get my first job out of school. And he did that exactly. Everything that Tony said, he did all that. He kind of coached us, but he just did it through, he led by example, but he did all the things that Tony mentioned. And then it's like, yeah, success, leaves clues.
Success leaves clues. I like that. I would say focus on what game you're playing, what position everybody on the team is playing, and how they can play that position well. And a lot of times it has nothing to do, or I shouldn't say nothing, less to do with anatomy and physiology and neuroscience. It does have something to do with that, but understand what game you're actually playing. We're in the experience business. We're in the attention business. And that's the actual thing that we're providing. Well, back on Tuesday, I think I came up with a new tagline, or this one came to me during the show, the #1 morning radio show for private practice physical therapists. I don't know. Maybe we'll flesh it out, knock some words down, but that feels like what we're aiming to do.
Sounds about right. I think so.
About right. All right. We'll
self-acclaimed.
Yeah. Just say it. As long as one dentist says that this is the best toothpaste, it's recommended by dentists. 2 dentists equals dentists. Follow Dave on the Dave Kittle Show on YouTube. Tony will take you from 0 to paid in his group as well. And I sometimes drink beer, usually later in the day, and interview people. We'll see you guys on Tuesday.